The use of pragmatic and cluster randomized controlled trials can support the generation of important medical evidence, but advances in approaches to conducting RCTs also present ethical challenges. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Charles Weijer, a professor in the departments of medicine and philosophy at Western University in Canada. Dr. Weijer has co-authored a perspective article about the ethical issues associated with pragmatic and cluster RCTs as part of the journal series on the fundamentals of medical ethics. Dr. Weijer, how do pragmatic trials differ from explanatory trials, and in what types of settings are they typically conducted?
So explanatory trials are really the familiar trials that we think of as part of the drug and device approval process. These are trials that are designed to explicate mechanism to improve our understanding of new drugs and devices. And these are in contrast to pragmatic trials. Now, pragmatic trials are different because rather than purely looking at mechanism, they seek to directly inform physician, patient, or health system manager decision-making. So that's really the key difference. It's all about informing decision-making rather than mechanism. Pragmatic trials differ in a number of ways. They tend to have relatively few eligibility criteria. They tend to be conducted in more diverse clinical settings. So rather than just academic medical centers, they might be conducted in community hospitals or primary care practices. They may take a more flexible approach to the delivery of the intervention and allowing for some flexibility in the way that the intervention is actually taken up in practice. And importantly, outcome measures commonly should be patient-relevant outcome measures. So pragmatic trials are a really important approach to trials that seek to bridge the gap basically between explanatory trials conducted in the drug and device approval process and creating the evidence that's needed by doctors and patients in practice.
You say, though, in your perspective article that pragmatic RCTs present ethical issues related to assessing research risks and protecting vulnerable people. Can you elaborate on those concerns and perhaps how they might be mitigated?
There's a lot of interest right now, and rightly so, in pragmatic trials. I think when one reads about it, one gets the sense that people are talking about pragmatic trials as a kind of design. So pragmatic trials are not a design. They really reflect the intention of the researcher, of the clinical trialist, to produce results that will be immediately applicable in clinical practice. These trials raise a number of difficult ethical issues that we talk about in the article, and these issues include several. One feature of pragmatic trials is that they tend to have a minimal eligibility criteria. And so an objective of these trials is really to take all or most comers so that the trial population really is strongly representative of the target clinical population. A result of that is that basically a very diverse set of patients is included in pragmatic trials. And that means more patients are going to be vulnerable for a variety of reasons. So they may have fluctuating capacity, they may have more comorbidities and be at higher risk of side effects from treatments, or they may be socially marginalized. So one of the challenges then is how do we sort of structure adequate protections for vulnerable participants in pragmatic trials?
In your article, you also discuss cluster randomized trials. What does the design entail there, and when are they helpful?
So there are two broad types of randomized controlled trials. There are individually randomized trials, which is the standard sort of randomized controlled trial that people will be familiar with. Cluster randomized trials, rather than randomizing individual patients, will randomize entire groups. And that could be hospitals, it could be communities, it could be nursing homes, what have you. So that's the main difference between cluster randomized trials and individually randomized trials. Cluster randomized trials are used in a number of scenarios. One is where the intervention is basically delivered to the cluster or the group as a whole. So think here of public health interventions targeting entire communities. Well, there's an instance where you can't do an individually randomized trial. So because the intervention is delivered to the entire community, you have to randomize communities by necessity, even if you're tracking health outcomes of individual community members. There's also interest more recently in doing cluster randomized trials on individual level intervention. So these might be treatments administered to patients or treatment policies or education delivered to patients. And those trials, in that circumstance, individual cluster trials, I think raise particularly difficult issues. I mean, one is just the fact that cluster randomization raises a series of methodological challenges, including the fact that these trials tend to be statistically inefficient, and also they're more vulnerable to bias than individually randomized controlled trials. So generally speaking, when it is possible to do an individually randomized trial, one ought to be going down that path. So really, one of the first ethical questions we want to ask about cluster randomized trials is, in fact, whether that trial design is adequately justified, because that's not only a scientific question, it's an ethical question. These trials are larger than individually randomized trials, which means that more participants will be exposed to the risks and burdens of study participation. And because of the increased risk of bias in these studies, their social value can be put at risk. So it's very important that the choice of design be carefully justified when choosing a cluster randomized trial.
So just to take one example of an ethical issue, when is a waiver of consent acceptable for either pragmatic or cluster randomized trials?
So I think one of the exciting things about the Fundamentals of Medical Ethics series in the journal is that it highlights the importance of advances in medical science, new medical technologies. It really highlights how there's an opportunity with new technologies basically to ask new ethical questions and at times to re-examine the foundations of medical ethics. I think the issue of waiver of consent is a great example of the latter. Many national research ethics guidelines contain provisions for a waiver of consent that most of them say something to the effect that if obtaining consent is infeasible and if the risks posed to participants are minimal, then a research ethics committee can grant a waiver or alteration of consent. So that's something that we've used for a long time. Pragmatic trials and indeed cluster randomized trials as well have brought the use of waiver of consent, I think, into question. Because pragmatic trials, for instance, are conducted in clinical settings, community hospitals, primary care practices that really lack research infrastructure, it's difficult to obtain informed consent in the usual way. And what I mean by that is sort of standard written informed consent, often administered by a research coordinator. Well, in a busy community hospital where there are no research coordinators, administering a 30-page consent form is not feasible. And so some people have argued that in pragmatic trials, we should be seeing more use of waivers of consent because of the sort of settings where these trials are conducted. To me, I think that conclusion is problematic. And what it shows is a problem with how we understand the waiver of consent. The waiver of consent has one set of criteria basically for alternative approaches to informed consent and the waiver. And if you satisfy those criteria, well, why not just go with the waiver? That's easier. I think that's problematic. Where possible, we ought to be exploring alternative approaches to informed consent because those options are more autonomy-preserving options. So I think pragmatic trials throw into question, perhaps, a broad use of a waiver of consent in these settings and say that we need to be more innovative here in this space in terms of how we operationalize respect for autonomy. We ought to be looking at approaches including perhaps e-consent, where patients in busy clinical settings are consented via a tablet, for instance, or perhaps integrated consent, where health providers themselves seek verbal consent from potential participants and then document that in the electronic health record. I think this is such a great example here of how new technologies here, well, we're speaking, of course, of new trial technologies, highlight a new way of understanding some fundamental issues in research ethics.
Finally, how should researchers involve patients and the public in the design and conduct of these types of studies? And why is community input important?
Well, patient and public engagement is such an important issue. The pragmatic trials highlight this in terms of the recognition that pragmatic trials really should have outcome measures that are relevant to patients. And how do we determine that? Well, of course, we have to engage patients, we have to engage the public in the design and conduct of trials to accomplish that. Patient and public engagement is so important for a number of reasons. I mean, it promotes trust in the research process. It demonstrates our respect for communities. And ultimately, it's a way of enhancing the social value of research. So from an ethical standpoint, I think it's so important for patient and public engagement to begin from the very start of a study in terms of choosing study questions, choosing study outcomes that are relevant to patients and communities, to involve patients and the public in thinking through how recruitment processes ought to happen, and indeed even in terms of helping design consent materials. The very good news for researchers and clinical trials is there's some evidence from a recent systematic review that indicates that patient and public involvement actually has a modest enhancement effect for patient recruitment in trials, particularly when people with lived experience of the condition under study are involved in the research team.
Thank you, Dr. Weijer.